As scheduled, we begin this session of the European School of Urology on the topic of adrenal surgery. First of all, I would like to to welcome you all in Tunisia. I would like to thank the European Association of Urology for allowing such sessions of the European School of Urology in Tunisian congresses, and this year for the joint Congress of the European School of the Tunisian Urological Association and the Pan-African Urologic Surgeons Association. This session will also be available on live stream so that our colleagues who did not have the opportunity to attend the Congress can profit from this course. Special thanks to Professor Gauzen from Germany and Professor Langerheisen, that's correct, okay, from the Netherlands, for coming to Tunisia to organize this course. Now, Professor Gauzen, you have the floor for the first presentation.
Good morning. Good morning and welcome. I know it's early time for this nice place, but I can see that a lot of people are here. One more time, I want to thank the organizing committee and presidents for this kind invitation in the name of European Association of the Urology and European School of Urology. We are doing this course with Dr. Langenhuisen, I think, during the last 5 or 6 years, and then really this catching a lot of interest from the young people, residents, and then we are believing that the adrenal diseases and then adrenal surgery is very important, and then it has to stay in the hands of the urologist. I want to just give you first the brief information about the European School of Urology and European Association of Urology. Sure, you are here and you hear this all the time. What's European School of Urology? What's European Association of Urology? But if you will see this in numbers and in facts, maybe this will be more clear for you. For a job European School and then European Association of Urology doing in the scientific field in the name of the urology. Firstly, and then the numbers are speaking. European Association of the Urology is the biggest urology association on the world. 18,000 plus members. It's no other urology association, even no other surgical association on the world has this number of the members. It's showing clearly the interest of the urologist because there are the big benefits as scientific, as training, as developing in this field for the young and also experienced urologist. Publications, maybe one of the important publications of the European School of the Urology. Sorry, this is jumping. Oh. They don't want to go back. This is one of these, the guidelines. Guidelines is just showing the current scientific trend with the evidence in one field, and has to be updated. It means the guidelines 5 years before are not the guidelines from today. That's why European Association of Urology guideline committees updating this every year, then they are really working on it. If you get this in your hands from the last one, this will show you the last trends, with scientific evidence in the field of the urology, which is then mostly it is the biggest and important guideline for the urologists on the world. Publications. We have the Platinum Journal. Platinum Journal, as you see, the impact factor is really one of the highest. Firstly, the highest impact factor in the field of the urology. It's showing clearly the scientific level of this journal. This is more than 35 years. We are publishing this, and then it's read by more than 20,000 urologists. And then the first in the field of nephrology and urology. And then this impact factors, 20 in in 2 years ago. You will see this year will be higher because we are taking care for the quality of the scientific papers we are publishing. But with the time we have seen this journal was not enough to publish this really scientific level than the number of the publications, because the field of the urology is supported with the technology, from technology to microbiology to pathology. It's the huge field. To develop this in the different fields, now we have done 3 journals, and one of them the European Urology Focus, then Oncology, then the Open Science. The Open Urology journal is gaining more interest because not everybody is a member of one society and has not the access to any journal. To share these papers with the urologists worldwide without even being anything, just go log in internet, go in Google, you can find these papers, which is also very important and easy to reach for a lot of urologists. European Urology Today is our newspaper, giving them the latest informations about the current situation, what we are organizing, what we are doing, projects, studies, then what the people are doing. Patient information, during the last 3 or 4 years, is getting more and more importance. We have to inform our patients. Actually, in the practical field, everybody knows when you are talking with a patient, he or she will understand and to talk about the first 3 sentences. Thereafter is then blackout mostly. So it's very important to keep the patients informed sufficiently. If they are not able to understand this, the relatives or somebody has to understand the situation and accept and give you permission to give them the best quality of the treatment. And we are producing this patient information in 18 languages, which is actually enough for a small world. We have in our website a Eurosource. When you are going to Eurosources, including videos, papers, during the COVID times, a lot of webinars, and then really scientific content is more than 60,000. Whatever you are doing in the urology, whatever your interest is, you can go and log in Eurosource, whatever you are interested in, and your questions will be answered in Eurosource. Sure, they are the basic access for the basic knowledge. For the more specific fields, you have to be member. I will explain you what is the benefit to be a member. Online learning, during the last 3 years, we have seen, and this was very useful during COVID times, as we couldn't travel free. We cannot still travel free. But these 3 years, they have shown us how much this can be important. Online learning, online courses, webinars. This was another way of communication. I think this will be more and more important, mostly of the parts of the world like Africa. You cannot go and reach everybody in Africa easily. There are a lot of restrictions, but if you are going through the webinars or Eurosource, the scientific level will be then available for all our colleagues. All the topics they have been done here, as you see, prostate cancer, kidney cancer, bladder cancer, male lower tract, bedwetting, nocturia, all the headlines they have been covered here when you want to go and learn something. Education. I think school means education. We are taking care spatially for the young urologists and their residents. But it means not that we will not taking care for the experienced colleagues or the developing in their field, when they are developing in their field and they want to learn something new and maybe practice more. Because of this, maybe the truth is mostly the young urologists will benefit mostly maximum from the European School of the Urology in the name of the learning, scholarship, online education, and exchange programs. I will explain it, how much this can be important and possible. These are our objectives, what's our aim, how we are developing our work and studies. The new chairman is Professor Liatsikos from Greece, and all the committees, really very experienced people. For the school, we have more than 200 European experts and opinion leaders. Then also the technical part, operating part, we are working with 60 European experts for laparoscopic, endoscopic, and robotic surgery. Online education is gaining more and more interest. You can see here how many people we could reach during this COVID pandemic. The surgical education, online courses, webinars, not only for the urologists, the urology nurses are also in our spectrum. Urology, when you're going to operation theater, is a teamwork. When you are going and then you think you are the best surgeon of the world and you have not good assistant, or your nurse cannot understand you, your anesthetist cannot do anesthesia for laparoscopic surgery, you will be not able to succeed. So this is the teamwork, and we have to take care also for the nurses. Which e-courses we are providing? As you see, all the objectives are here listed, the main objectives. We are not finding this from ourselves. This is actually the feedback coming from our members, what they want to see, what they want to learn. This is one of our important projects. We have started with this, I think it was 2019. As the European School of Urology, they has developed different training programs, and they have been accepted very well on the world. We decided to start with a European project. Why European project? Because of the financial issues, because European Union is supporting such kind of projects. This finance can be then used for the parts of the world like Africa, Asia, where actually people cannot be very well trained because of the physical issues. This is the SIZE program, Standardization in Surgical Education. It means when we are providing a laparoscopy training for the European residents in Prague, the same training with the same quality has to be possible for somebody in Pakistan or Philippines or somewhere in Africa. This is the aim of this program, and we have included in this program till now, I think seven big centers in different parts of the world. Then now we are following the process. If this will be successful, we will include more clinics from the world for this program. This is the mission what we are looking for. We want to train the surgeon standard to allow them the highest quality of education, and also guide them on surgical training, then let them achieve competence. This will be only possible with such kind of standard programs. Otherwise, everybody is giving a training. It's also working, I'm sure, but nobody knows about the effects. Nobody knows about follow-up. Nobody knows if these people going and producing thereafter something. This information has to be collected, and this will be the aim, one of the aims of this study. As you see, this is going very well. This is just for another presentation about the study, but I want to just give you brief information, as you could see. Our webinars are free. If you are a member or not, you can go and join the webinars and collect continuous medical education points. And if you go and see our program, webinar program, you can choose one of these webinars, then not important where you are, the information will be delivered for you. This is one of our important programs. As I've told you, we are focusing on the young urologists and residents. In this part, every year, European Association of Urology providing for more than 400 last year residents in urology in Prague, a really comprehensive training course in practical is also in theoretical. It means then 4 days long. This is massive information coming from the experts, then thereafter hands-on training programs. For this program, we are accepting from all the world last year residents. Also the residents from Africa or from Tunisia, wherever you are, if you are last year resident, you can apply for this program, then we will be very happy to accept not 10 residents, sure, but at least 1, 2 residents to give them a brief overview, what's our aim, what we are teaching, how is the training program for the European residents. We are accepting, I think, every year from 1 or 2 or 3, the non-European countries are welcome and going to application. Please applicate or let your residents send the applications for this program. We have different organizations. One of them is then Europe Best. This is for the, again, 3 days training program for the young urologists. We challenge the experts, hands-on trainings, then discussing the clinical case, keep their information fresh, and then improve it. Art and Flexible, this flexible urology with the single-use instrument that has been part of our life. And then for all the urologists, the flexible ureteronoscopy has been a standard tool, so everybody has to learn it. Even when you are working in andrology, you have to perform flexible URS. So for this program, we are taking our residents and checking and training them in a 3-step program. This is, as you see, this is for the third-year residents, because in European program, the third-year residents, they have to be able to perform flexible URS. As we are doing here, we have courses as national societies meetings everywhere on the world. It's coming to, if you will apply for it, ask for it, European Urology will do the best to make it possible for our colleagues outside of Europe. Master classes is a long list. This is for the master classes, mostly for the young urologists, practical training, not for the residents, but you have been urologists, you are training, you have a main interest, you are focusing, for example, for BPO surgery, endoscopic surgery. So all these master classes are for you, giving you theoretical and practical information and with live operations during the 2-3 days, depending on the program. We have section meetings. As you see, European Association of Urology is very well structured. Really like a state, as we have talked with Hans today, it's like a state. There are a lot of parts, and this is a job for everybody in European of Urology if you want to come to support and enjoy to work with the experts. And I'm chairing proudly I can say, maybe one of the biggest sessions in the European Association of Urology, which is the European Society for Urotechnologies. We are focusing just for technological developments in the urological field, flexible urology, lasers, the latest prostate surgery, robotic arms, camera arms for the laparoscopy, different instruments, energy sources, whatever, or augmented reality, 3D modeling, whatever is done in technology, to do with technology in the urology is in our field, and we are focusing on it. Important part. When you are coming or joining an association, it has to be a benefit for you, not just a badge there, which is nothing. You need to know what you want to get from association. You are a young urologist, you want to learn more. You cannot afford to go and to learn something abroad, so it's a good chance for you to be a young member of the European Association of Urology. You will get a chance for scholarship, you will be supported, you will get reduced fees. It's actually, if you are looking for something, everything is available. But if you are sitting at home, and then, I have to give them one example, I like it. You have a girlfriend, And then you are sitting at home and waiting that she will call you. Maybe she will never call you. Better you can call her. Better call European Association of Urology. Otherwise, maybe nobody will call you. This European Association of Urology, no secretary will find you and call. But if you will go and ask for something, you will get it, I'm sure. This scholarship for 1 year is possible if you are providing a nice project. Clinical visit, 3 months. We are giving 2,000 to 3,000 euros cash. We are providing you eating and drinking and accommodation. You have to just apply. Maybe most of the people, they don't know it. If you are a member of European Association of Urology, you can apply for a scholarship. You need just one PubMed publication, which is actually showing your interest for us. If you go, for example, you want to learn flexible, you want to go to Germany, you can say, I want to go to this clinic in Germany. I have an acceptance letter. Please support me. I'm a scientific guy. I want to learn and then do it in my country. You will see, you will be supported. But take care. The application deadlines are January, May, and September. So if you will apply in time, you will get the chance and the money. These are good news. The bad news. Bad news is you can get this chance one time in your life. So use this chance, then apply for a scholarship. Fellowship programs. If you are working specially for laparoscopy, you want to learn, let's say, laparoscopic adrenectomy, you want to go to Dr. Langenhuisen to learn it, you can apply for it. So this will be also supported financially, also scientifically. Visiting professor program. You are already an expert, but you want to exchange the information and you want to see what are your colleagues doing in other clinics. You are good in your country, you are top number one, but exchanging the information is always useful, and this program is for you. Membership. Very, very scientific issue. All the issues are scientific if it's going through the finance. Nowadays it's getting more and more harder. But at the end, if you're not showing interest and investing in one field, you will never gain something. So if you want to be better in the urology, you have to invest in investments starting with a membership. When you are going to be a member of European Urology, you see then what will be then possible for you. Scientifically, the world will be open for you. This is one. If you want to get chances, learning more, publish more, scholarship more, this will be open for you. But especially for the young guys, junior membership is an excellent chance or excellent door to open as a fourth door. This discount, I found it very commercial. Always sure, it's if you're a member, if you're even a club member, you will get discount. At the end, it's like I have given in the example. Call us, contact us, write something, say hi, how are you? The secretary will answer you. Thank you. What can I do for you? But it's not like in a hotel or in another field. You have to be structured. Not just to make a girlfriend from the secretaries, but you can ask for something. So this will be answered sure. Thank you very much. One more time, coming and showing your interest here. Dr. Langenhuisen is one of the best experts I have seen on the world in the field of adrenalectomy. Now we will hear from him really very, very valued lectures, and we will enjoy, I'm sure. Thank you very much.
Thank you, Dr. Gozen, for this excellent summary about EAU importance in Europe and around the world. And we move to the next talk. Please, Dr. Langenhuisen.
Good morning, everyone. I would like to thank the organization of Pausa and the Tunisian Association of Urology for inviting me. It's my first time here in Tunisia, and it looks like a very beautiful country, so I'm really happy to be here. Thank you for inviting me and having me here to talk about adrenal surgery. It's one of my main topics back at home. I do a lot of minimal invasive surgery on the renal aspects, but also on adrenal. And I'm happy to hear from the chairman, who I just spoke to, that adrenal surgery is still in the hands of urologists here in Tunisia as well, which really makes me happy. So to talk about adrenal surgery, we have to talk about endocrinology. I know this is a difficult topic, so I will start with this topic, and then after this, the surgical part comes. But I think it's really important to talk about endocrinology and indications for surgery, and also how to prepare your patients for surgery. So these are my conflicts of interest. And today I would like to talk to you about guidelines. Are there any guidelines from the EAU or other guidelines? And how about the surgical indications? And then specifically the adrenal incidentalomas, always a difficult topic. I will look at indications to remove an adrenal. Then something about perioperative preparation for surgery, and my take-home message is to end with. So basically, bottom line is that there's no EAU guidelines for adrenal surgery. So urology is not really strong in providing guidelines, but the Americans are doing a little bit better. So there's the Endocrine Society, but also endocrine surgeons from the US who developed guidelines. Basically, there's one on incidentalomas from Europe. There's one from the American Association of Endocrinologists and Surgeons, also on incidentaloma. And there's adrenal guidelines on adrenal cancer from the ESMO. And there's 2 guidelines on incidentaloma, basically from the Endocrine Society as well, not involving urologists. And to my opinion, these guidelines are well documented, but they're very minimal on the surgical aspects of adrenal surgery. So I would like to state here that I think it's time for adrenal guidelines from a surgical perspective, and that's what we're working on currently within the ERNs, the European Reference Networks, to start developing guidelines for adrenal surgery, and these are mostly rare diseases, obviously. So let me first introduce you to my patient, who was a 67-year-old male patient who came to me with an incidentaloma, meaning this adrenal tumor was found incidentally with scanning, with the CT scan, and it was a 5-centimeter tumor with a Hounsfield units measurement of 35 of the adrenal. This patient had a history of lung carcinoma 10 years ago, and currently no other complaints, specifically no hypertension complaints. So basically, there's 2 questions we have to consider when we have these patients with incidental adrenal tumors. Is it a malignant tumor? Should that be a reason to remove it? And is it hormonally active? So then this flow chart is really helpful. I would recommend to read this paper by Raimondo. Basically, if you look at the flow chart, and you see a tumor of the adrenal that's less than 4 centimeters and has clear benign characteristics on imaging, on non-contrast enhanced CT scan, then basically it is an adenoma, and that is with Hounsfield units below 10. And then specifically in the older patient, you can stop doing follow-up. In the younger patients, you can discuss to keep these patients in follow-up. All other incidentalomas, so larger than 4 centimeters, or when there's higher Hounsfield units on this non-contrast enhanced CT scan, then you have to consider the options and discuss this in your multidisciplinary team. Should I go for surgery straight away? Should I do another CT scan with contrast, or perhaps even PET scanning? Or should I start doing follow-up? So these are the tumors that we have to look at, and definitely discuss them in your multidisciplinary team. And then if you do a contrast-enhanced CT scan in these patients, and you find high washout, so over 60% of washout after 15 minutes, as you can see here in the slide, then it's a benign tumor probably, and you can start doing follow-up. All other tumors that have very low washout of contrast are suspicious of adrenal cancer and should be considered for surgery. Another option would be, if it's not that suspicious, to do follow-up scans. That could be a non-contrast enhanced scan after 6 to 12 months. And then with significant growth, there could be another indication for surgery. So that is the, let's say, the radiological aspect of adrenal tumors. And then the endocrine aspect is really important. So that's why we work in our hospital. You see our center here. It's just been removed the last couple of years, and it's still going on, the reconstructions. But it's become a very beautiful hospital in Nijmegen, and I invite you all to come to Nijmegen and to see us work on adrenal surgery, and you're most welcome to join us for a short fellowship and the cooperation. But we work in a multidisciplinary team, so we have this team of internal medicine doctors, radiologists, nuclear medicine, and lab experts who work together with us in this field, and we have a multidisciplinary team meeting every 2 weeks to discuss all adrenal tumors that are in the field. And we work on a national level in the Netherlands in networks. You see more and more that the hospitals that do very little adrenal surgery per year, they stop doing it, and it's being more centralized. So we are on the top here as well, on the left of the image. So it's more and more centralized adrenal surgery in the Netherlands, where currently you need to do at least 10 operations per year for the insurance companies to provide the money for this, for reimbursement. So this is increasing, and I believe in working in networks, not only with your multidisciplinary team, but also on a national level. And we work on an international level. We are one of the ERNs, so the European Reference Network, so 24 European Reference Networks sponsored by the European Commission. And we are in Eurogen, so the urological ERN, and I'm chairing currently workstream 3, which is about rare urogenital tumors, and that consists of penile cancer, testis cancer, but also adrenal cancer. And we collaborate on a European level at the moment with almost 60 other expert centers. We have case discussions, we have education programs, so webinars as well, and we also think of developing guidelines for adrenal surgery. And we do a lot of international research projects as well. So I think this is the way forward. Adrenal surgery is mostly about rare diseases. So I think this is the only way to improve our surgical expertise and our research projects. So then we have to dig a little bit into endocrinology. It's probably a long time ago for many of you, but you may consider that the adrenal consists of a cortex and a medulla. In the cortex, there are 3 important hormones being produced, which is the salt hormone aldosterone, the sugar hormone cortisol, and the sex hormones like testosterone. You see them here being produced in the different layers of the adrenal. You have the zona glomerulosa producing the aldosterone. If something goes wrong, you get a primary aldosteronism. Then in the zona fasciculata, the cortisol is being produced. If it's being increased, then you have a Cushing syndrome, and you see in the zona reticularis the androgens being produced, and these are quite often raised when there's an adrenal cancer. And then finally in the medulla, this is more a neurocrine part of the adrenal, the adrenalins are being produced, and if they are too high, then you have a pheochromocytoma. So you may remember from medical school that the RAS system is about production of aldosterone, so under influence of renin produced by the kidney and being transferred into angiotensin through the liver. The aldosterone is being increased from the adrenal. So if you have a very high aldosterone production in primary aldosteronism, you see an increased aldosterone, and then by a negative feedback system, the renin gets very low. So the RAS system is important for homeostatic reasons, for the fluid balance of the body and the blood pressure. And if anything goes wrong, you get high blood pressure. So basically, what aldosterone does, it influences the distal tubules in the kidney, where it provides an exchange of sodium and potassium. So you lose potassium from the kidney with primary aldosteronism, and you get hypokalemia, and you reabsorb sodium, and you get influx of water as well, and high blood pressure. So high blood pressure and hypokalemia are typical signs of hyperaldosteronism, and this is quite often the case in almost 5% of all hypertension patients, at least in the Netherlands and probably worldwide as well. So you diagnose this by this aldosterone-renin ratio, but also by a salt loading test. So you provide high doses of salt to the patient, and then you check for the negative feedback system, whether the aldosterone decreases, and if not, you have a primary aldosteronism. And then you have to localize which of the two adrenals increases this aldosterone, and you do this by imaging. So you do a CT scan to see if there's a unilateral adenoma producing this aldosterone, and our current guideline is that you have to do a functional test as well with venous sampling. So you collect the blood from the adrenals and measure the aldosterone level to see which of the two adrenals should be removed. And then in about 40–50% of the cases, indeed you have a unilateral aldosterone-producing adenoma, which leads to surgery. So the other 50–60% of the patients have a bilateral disease. They're being treated with aldosterone blockers, so not surgically. And the 40% are being treated by basically laparoscopic adrenalectomy. So then we go to Cushing's syndrome. So if the cortisol is too high being produced in the zona fasciculata, you get a hypercortisolism, Cushing's syndrome. And this is a very serious disease, a lethal disease. Patients have sort of a metabolic syndrome-like disease. They have very bad skin quality, bad hair quality. It has a lot of effect on the brain as well. So you see depressions in these patients, even psychotic events. So a very serious disease. And atrophia of muscles, as you can see in these patients, and this central fat depositions, like you have this humpbacks at the neck and a central deposition of fat in the abdomen. Serious disease, and finally it is lethal if not being treated adequately. And it's a very rare disease. In the Netherlands it's about 3 in a million, and worldwide as well, very rare disease. So what is the cause of Cushing's syndrome? I think it's important to know that about 80% is being caused by a brain disorder. So in the pituitary gland, there could be an adenoma, a growth, a tumor growth, and produce ACTH, and this ACTH stimulates the adrenals to produce cortisol. So this is about 80% of the cases is the cause of Cushing, and then we call it Cushing's disease. And the other 10–20% is caused by an adrenal tumor. The test to show there is a hypercortisolism is a dexamethasone suppression test. So you give dexamethasone in the evening, you measure cortisol the next morning, and then because of the negative feedback system through CRH and ACTH, cortisol should decrease with this dexamethasone. If it does not, there's an indication that there is a hypercortisolism. Then you do a confirmation test in your urine of 24 hours. And you do a measurement of ACTH to know whether it's being produced in the brain or primarily in the adrenal itself. And then you have these different imaging studies to see where the production comes from. So you do in a high ACTH measurement, MRI of the pituitary gland to find the adenoma in the brain. And if ACTH is suppressed and it's not being caused in the brain, then you should do imaging of the adrenals. So if the cause is a pituitary gland adenoma, obviously the neurosurgeon has to come into the field, and otherwise, if the adrenal itself is causing the high cortisol, you do laparoscopic adrenal surgery. And until then, because of the severeness of this disease, you have to treat these patients, for instance, with metirapon to block these effects of the cortisol hormone. So this is our patient, as I said, a very serious disease, lethal disease, and if not treated, patients eventually die of this disease, and after surgery, it takes about 1 year, and you have the same patient 1 year later. So it's really spectacular cure of the patient. Although we know from our research projects that these effects of cortisol, they last, and even after a year, patients tend to stay fatigued and still have some complaints. So it's not completely cured in many instances, but it improves by surgery. And same for pheochromocytoma, so the adrenal producing tumors in the medulla of the adrenal. Basically, from tyrosine in several steps, the adrenalins are being produced and the noradrenalins, and these are stored in so-called chromaffin granules. So within the medulla of the adrenal, these adrenalins are being stored there, and then in pheochromocytoma, a sudden burst of these granules can lead to specific complaints, and this is what happens in pheochromocytoma patients with a very impressive clinical presentation. And again, also this is rare disease in the Netherlands, but also worldwide, and the specific complaints of a pheochromocytoma patients are these bursts of adrenaline, so they have high blood pressure going up and down, all the way up to 250 or even 300 millimeters of mercury. They have attacks of sweating, anxiety, and palpitations. Very typical presentation. Also a very dangerous disease. Severe sequelae could occur in the brain or in the heart. And to prove that there is a pheochromocytoma, you need to find the adrenalins, either in urine or in the serum. So this is the test to do, and you have to do your imaging to find which one of the adrenals is causing the high adrenaline. So you do CT scan or MRI scanning, and if you find one, you can also do FDG PET scanning, because in about 10% of these pheochromocytomas, these are malignant tumors, and they can indeed metastasize. So most of the times, pheo is coming from the adrenal cells, and if not, it can come from all the sympathetic nerve ends along the spine, and then we call it paraganglioma. And typically, a substantial percentage of patients have a hereditary pheochromocytoma. You may all know von Hippel-Lindau's disease or MEN2 syndrome. They typically form pheochromocytomas in their adrenal. And there are so-called genetic mutations like SDH mutations, and then specifically SDHB, which produces malignant pheochromocytomas. So you always have to check for genetic alterations in these patients. Therapy is surgery whenever possible. For instance, in MEN2 syndrome and VHL, there's a very low chance of malignant tumor. These are mostly benign pheos. And we know from these diseases that there's quite a recurrence rate. So it could be a reason to a partial adrenalectomy in these patients, so cortex sparing. And all malignant pheos are very difficult to treat. It has a poor prognosis. And if surgery is not possible, you have to treat these patients, for instance, with radioactive MIBG treatment. And then the reason to treat is basically to get these adrenalines down to get a better quality of life for the patient. So I think it's important to know that these are the most prevalent indications for surgery from the endocrine perspective: primary aldo, Cushing, so cortisol-producing tumors, and pheochromocytomas. And obviously, the incidentalomas that are suspicious of adrenal cancer, so over 4 centimeters, and suspicious on your CT scan imaging, should be treated. And then we see, obviously, also during nephrectomy, as urologists, we quite often see that there's ingrowth of the upper bowel tumor in the adrenal, or a suspicious lesion on preoperative CT scan, and in that instance, you take out the adrenal as well. And we quite often have solitary metastasis from all kinds of disease that we have to treat, from lung carcinoma, renal cancer, or melanoma, that could be treated by laparoscopic adrenalectomy as well. Just briefly about perioperative preparation. So again, please consider working in your multidisciplinary team with your endocrinologist. And specifically in pheochromocytoma, this is truly important because you have to give these patients alpha blockade because of these bursts of adrenalines. Blood pressures can go everywhere during surgery, and you don't want this. You want it to be safe. And then a post-operative intensive care unit is also very helpful. In Cushing's disease, because of the high cortisol, the other adrenal tends to get suppressed, so it's important to give a stress hormone scheme with hydrocortisone. And basically, with every adrenal incidentuloma, you have to check for these two diseases. So pheochromocytoma and Cushing should be excluded before starting to do surgery. This does not count for primary aldosteronism. You only check for primary aldosteronism if there's a hypertension in this patient. So back to our male patient with this incidentuloma. As said, no other medical history, so no hypertension in this patient. But diameter was over 4 centimeters, as is stated in this flow chart I showed you, with higher Hounsfield units, clearly over 10, so it's not a benign tumor. And what imaging would you suggest from this? Anyone? I hear CT scan. I think that's correct. So do a contrast enhanced CT scan. We did this, and it showed that indeed the washout was very low, so below 60%. So there's a clear suspicion of a malignant tumor in this adrenal. And then we performed PET scan, as you can see here, and we showed that only the adrenal enhanced on the PET scan imaging, and no other lesions were found in the body. And then we decided to remove this adrenal by laparoscopic adrenalectomy. And quite surprisingly, it appeared that it was a metastasis from the lung carcinoma that was already 10 years ago. So for now, I would like to conclude. My take home is that I truly believe that the multidisciplinary team is really important. To work together with your endocrinologists, work in networks. We do this a lot in the Netherlands. We do this a lot in Europe. I'm really curious to hear how it is in Northern Africa or in the African countries. And important is to consider all these radiological aspects and hormonal screening, specifically because you have a lot of perioperative measures that should be taken into account. And as I hope to have shown you, that many indications for adrenal surgery are really urgent. These are serious diseases, and finally, although not all malignant tumors, they're finally lethal for the patients. Okay, so thank you very much.
Thank you very much. So you continue, or Dr. Gozen?
If there's questions.
Are there some questions in the audience? Apparently no questions. So we're behind schedule, so we continue.
Okay, thank you.
Now we have seen the critical part. Now we are coming to easier part. This difficult part is taking a decision, putting an indication. It's the most important part. The other part is that just a practical job. Sure, it's also important, but I'm believing always the correct diagnosis, correct indication. This is actually most of the job. Now we have taken the decision, we have to remove the adrenal. For removing the adrenal laparoscopically or minimally invasive way, there are some accesses, some different techniques, methods. We want to give you now the practical aspect, how we are doing this, what are the steps for this kind of the approaches. My part is retroperitoneal prone and mini laparoscopy for removing the adrenal gland. Just give you, I have given already to you what's done European Society of Urotechnologies. We are dealing with the novel technological developments in the field of urology and their application in the clinical practice. And our objective is to collaborate in training, knowledge, exchange the information with the European and non-European urologists. To be honest, ESUT is the world eye for the European Society of Urology. We are focusing on the world. We are looking what our colleagues on the world are taking care, what they need, and then we are aiming to collaborate with them as much as possible. The ESUT was the first section of fully member of European Association of Urology. This is one of the cornerstones of the European Association of Urology. And as you see, we are collaborating actively with the urologists on the world for support them in every level, especially in training for the new technologies in the urology. Now, laparoscopy, excellent tool, gold standard technique to treat the broad spectrum of the adrenal diseases. After we are discussing during the last 3 years, what's the gold standard? It's no gold standard, actually. This is just time dependent. It has to be the current standard. Now is the standard treatment is the laparoscopy, maybe for removing the adrenal gland. But maybe in the future we will have another standard technologies, maybe the robotic technology or maybe another technologies. But the laparoscopy has a lot of advantages, as you know all. I don't want to go through this one more time, but it's a lot of advantage for the patients. Just this the main picture. We have removed, as I was resident, adrenals with these big chevron incisions or big lumbar incisions. But with the laparoscopy, as you can see, we can make a huge difference in the life of our patients when we can go and operate them in a minimally invasive way. What you need when you are going to operate, you have taken the indication you want to go and operate your patients, your equipment has to be filled, it has to be full. Never go with missing equipment for a big operation. This is always a big adventure. When you want to go and operate in the extraperitoneal area, you have to develop the space. You need a balloon trocar. You need extraperitoneal trocars, mostly without knife. They have the blunt-ended trocars. The instruments, you will need them actually standard instruments, but don't forget, adrenal gland is not something to grasp. It's very fragile, so you need blunt instruments, and you have to just not to touch, just to go and dissect carefully. You need clip appliers because of the big vessels around. Don't forget, adrenal never has only one vessel. There are vessels coming from everywhere, as I will show you, from diaphragm, from kidney, from aorta, from everywhere. So you need to control them step by step. If you will clip just one vein, don't be very happy. You have to take care for the other vessels. And if it's available, a sealing device, 5 millimeter or even 10 millimeter, will be very, very helpful when you are going to perform adrenal surgery. Laparoscopy, robotic surgery, it means, or endoscopic surgery, it means you have to see. If you can see better, you can perform more precise surgery, you will be more successful. So you need, if available, at least HD screen. I can remember I went, I have to an African clinic, then they asked me to operate a kidney. As I went to operation theater, it was a normal TV there, just you have done in your room. And it was really a big adventure to remove this kidney. So if you have done at least an HD monitor in your operating theater, or maybe 3D, or maybe 4K, it will be excellent. Please don't forget, when you are going to look and you're going to see a movie at home with your family, you have 4K in your room, and then in your operation theater, it has to be the normal. That's what we need when we are going to operate. Access. Transpersonal access, Dr. Langenhuisen will give you an information. My part is retroperitoneal posterior or lateral. It means you can access retroperitoneal area from the posterior side or from the lateral side, as you can see here. It's actually the shortest way to reach the adrenal when you are going to operate adrenal laparoscopically. If you want to have a good access, you have to know the surgical anatomy. The surgical anatomy of adrenal and the retroperitoneum is not easy, and this also is not easy to understand. They are teaching us, or old school, I want to say old school or previous school, let's say, telling us, oh, you have to learn open surgery, it's important, then you can go on to operate laparoscopically. It's really not I want to just find my words carefully, it's not the reality. If you want to learn the anatomy, it's the best way is to go there laparoscopically. I will try to show you why and how you can learn laparoscopically better. The anatomy of the lumbar wall you have to know because of the trocars, which way you have to access, and once you are in retroperitoneum, you have to know what's your landmarks. Everybody's telling, oh, transperitoneal, oh, very big area, we know where we are, but as a urologist, you have to be ashamed. When you think, when you're retroperitoneal, you are losing your way. It's no urologist going to retroperitoneal, it's your home. All our organs are in retroperitoneal space. You never lose your way in the retroperitoneal space. Why? I will show you. How we are accessing. We have done the 11 and 12 cots. We have done iliac crest. Actually, if you know this is you are ready to access the adrenal from the retroperitoneal side. And these are our landmarks from outside. Mostly we are placing our trocars like this. I have a video showing the trocar placement, but at the end you will need one optic trocar, mostly 10 millimeter for the optic, or 5 millimeter is possible if we are going for the mini laparoscopy. You will need 10 millimeter working trocar for clip applier, energy devices, whatever you need. It has to be also in case of emergency, a 10 millimeter right side trocar is always advantage. If you are very experienced, you can use also 5 millimeter with 5 millimeter clip appliers or 5 millimeter bipolar devices, but this is the standard. Why we are choosing the retroperitoneal? Why you are not going transperitoneal? This is more direct access. You don't need to prepare organs like colon, duodenum, kidney moving a lot. You don't need it. Or spleen, cutting the ligaments. When you are going transperitoneal to adrenal, you have to change all the anatomy of the abdominal organs. You cut, it will be replaced, and you will then think that everything will go as normal as before. Sure, God is taking care for a lot of things, but we have to take care also for our patients. And I haven't seen in my life a bowel injury during retroperitoneal surgery, for example. I haven't seen trocar injuries a lot, maybe one or two because of I will show you in the complications part, when you can go and injury maybe the pleura, open the pleura, this is maximum. All the other complications, mostly for the beginners, are happening during the access complications during transperitoneal surgery. And complications are happening. This happened. You have an hematoma, you have an infection. Whatever you will have, this will stay in the retroperitoneal area, never go and make any problem for bowel or other intraperitoneal organs. What happened in the retroperitoneum will stay in the retroperitoneum. Tumor seeding, infection. If something will happen, this will not go somewhere in the abdominal cavity, but stay there, at least will stay localized, and you will be able to find it easier. Obese patients. Never think to operate these patients with the transperitoneal way. A lot of fat, long access. Once you are in, it's terrible with a lot of bowel segments, and colon is big. This is not a nice operation, starting with the difficulty putting of the trocars. Then when you are going retroperitoneal, you will be also faster. Then you see CO2 pressure will be not in the whole abdominal cavity, just for a limited area. If the patient has been operated, nowadays the patients they have been operated when they are coming to you, they are older, already appendectomy, cholecystectomy, maybe some bowel operations. Going in this abdomen through the transperitoneal way is actually the invitation for the complications with the bowel or other organs from the beginning. As you see, if you see these incisions in your patients, it has to be clear. You have to choose the retroperitoneal access. Sure, every access has disadvantages and also advantages. When you are going to retroperitoneal, this will be, you see, these are the advantages. But sure, transperitoneal approach has also some advantages. This will be given by Dr. Langenhuisen. But when you are going retroperitoneal, you will not touch the gastrointestinal system. This will be not a big problem for the lung. This pressure will not be high in all the abdominal cavity. They will be able to eat on the next day because you are not playing with the bowel a lot. Then you will need less analgesia. Maybe it's not the main point, but it's at least it's scientific data. Operation time will be shorter because you will go directly to your target, and then you will go directly to vascular supply, as I will show you. This is the lateral flank position. This is standard position in the urology. Then the prone position is jackknife position. Is the lower one. First, we have to create the retroperitoneal space. Once you are in with the first incision, you have to develop the space with the balloon. Why not with finger? Or why not with the others? If you go with your finger, then try to develop the space. It's a fat there. With every movement, you will create another layer in the fat, and this will fall on your camera. This will be like a hell. Better go once in, use one-time balloon, it will be one space. And when you are insufflating, take your time, insufflate the balloon at least in 3 different positions to create enough space for working thereafter. Trocar placement, better to see in the video, I will say, but these are the trocar positions when you're accessing extraperitoneally. This is where we are going in. The muscles, if you know where is the muscles, and then where is then the weak point, what you have to feel once you have done your finger inside, it's going to be easy. So I hope the video is going. Yes, it's going. This is the lateral position, flank position. This is the patient is padded. It's also important. This is then with the finger, you can do the cuts. where you will access. In Heilbronn, we are accessing this through the petit triangle. It is sometimes too high, but when you are going too high, you can reach better adrenal. These are done the trocar positions. Mostly, we have been taught during the first extraperitoneal surgery, never put any trocar over the 12th rib. Actually, it's happening nothing. Till 11, you can go and put the second trocar between the 11 and 12. Nothing is happening. This is the standard in our clinic. We are putting this. Once you make an incision, just feel the fascia. Just enter it with once. When you can open it, it means you are in. Open, you are in. No need to find the fascia, no need to work with the other things. Just the next time is go and bluntly enter the extraperitoneal area. It's all. Now, just make sure you are there. The other part will be done by the balloon. Through the balloon trocar, you can see how the space is developing. It's possible. It's with the optic, you can see how the space, you make sure, maybe at the beginning of your experience, that you're in the correct space, but thereafter it's sure where you can be. If the balloon is not going somewhere, staying there, you are in the extraperitoneal area. Just check the around, then put the other trocars under digital control. This, like you are doing during the operations, you can just move the peritoneum, push the peritoneum to make place for the other trocars. As you see, we are putting the trocars into the right hand, then the left hand is guiding the right hand. Yeah, we have used these metal trocars long time. It's really when you think like this, and this is directly the 13 millimeter trocar to avoid a leakage. And then this is when you are going in. You are in the extraperitoneal area. It's taking 2 minutes, not more than this. And this is, I hope it's working. Sorry. It's not working, this video. You can take it from under the videos. How we are entering when you are going to posterior access. Posterior access is maybe the best option when you are going to operate. This is just 2-3 centimeter going to adrenal. If the patient is thin, you are just on the adrenal. You have to just know the anatomy, because this is the other side of the mirror. You are looking always from the anterior side, and once you are posterior, you have to know the vena cava is on the different side, adrenal is on the different side. You need a short orientation when you are coming into this space, and plus for this space, you need more pressure. Then the patient is going in the jackknife position. I hope it's working now. I like this telephone. It's very good. Everybody has it. Maybe we can go to the next one and then working. He's working on it. Good. Maybe we can show it then later once you are ready. Just let me know. It's okay. The anatomy is really challenging. It's not easy. All around are the important structures. On the vena cava, very short vein on the right side. On the left side, on another big vessel. Just maybe on the left side is more critical. Then the pancreas tail is just coming. When you will not dissect carefully, you can injure pancreas. You will have a big problem. Or when you are going up, you can find the vessels from the spleen. It means really difficult surgery. These are the positions of the left and right adrenal. As you can see, it's really difficult to get an adrenal out. Video, I hope this will work. Okay. This is extraperitoneal, just the anatomy video from a good friend. When you're entering this is the Gerota fascia opened bluntly, psoas muscle. All the fascias around to open. And this, we are going on the left, this left side from posterior. This is the more or less than avascular area. It's going till diaphragm up. Now it has to be on the left side. This musculature is important for the orientation, not for the technique, but for the orientation. Then you have to go to the upper pole of the kidney and to open the Gerota's fascia laterally more to gain more access. Possible. If you go do it, then in the middle you can open peritoneum. These are the fascias around the adrenal. Once you are in, you will see then the kidney vessels directly. Fascias. The kidney is there. And as I will show you then thereafter, the localization, when you're going there and there, you will reach easily adrenal. Easily, it's sure, it's this the word. Easy is nothing is easy. This is easy is nice word, but it's not the reality. But as you see here, you're opening one fascia is up, one fascia is down, and you're opening this in the middle. You see then the perineal fat. Now, this is your way to go. When you are opening the perineal fat, then you are in the same space with the adrenal. This is looking like easy, like he's doing, but I can tell you it's really not easy surgery. You have to be always, for every step, very careful. And the complication rates can be very high during the first operations. Now, in the same space, then you see then there's spleen. If you know what is where, peritoneum, not to open. And this is actually kidney and then the adrenal. Now, I will come one more time to this operation and to this part. This was just till we are reaching this area and showing then the anatomical structures around. The anatomy left side and right side are totally different. It's not you cannot operate the right side, you're operating the left side. So right adrenal directly under the peritoneum. This then directly craniomedial to the upper pole of the kidney. The liver is then anterocranially, and then duodenum, when you're approaching from transperitoneal side, you will see anterocranially. And most important thing is inferior vena cava is on the medial part. On this other side, left adrenal is covered by the left colonic flexor. That's why what I have told to you, try to explain, when you are going transperitoneal, you have to remove it or you have to prepare it from your way. You are changing all the left colon anatomy. And this can go till down to the sigmoid. If you let the colon fall down, then this will be not the same function for the colon, believe me. And these are the fascia around the kidney. You see, it's kidney covered and adrenal on the other part of the on the kidney side, but it's another space, as you have seen with the fascias for the adrenal. Maybe this time now we have been at this step. Now we can go. We came there. Anterior renal fat now. Going around the kidney. I have learned from the Chinese surgeons how they are reaching the adrenal. They are reaching the adrenal when they are going extraperitoneal. First anterior, then posterior, and then on the tip, they are making this free. And you will see how we are doing this. These are the fascia still around. And this is the kidney. If you see once the kidney upper pole, and this will be, everything will be easy for the orientation. And this is the left side kidney. Go, go, go. Then hold the upper pole up. Then you will see, or you see already adrenal there. This is the adrenal gland. If you once go there, it's really short way and easy to reach the adrenal. But the vessels, veins and arteries, they are really very different. And they are not like always, there are a lot of accessory veins or arteries. So it means it's not only one main artery or vein, you have to take care for every step. Important vessels on the left side, short vein. On the right side, is the vessels are coming from the kidney hilum. This is actually one of the important messages when you are going retroperitoneal adrenal surgery. And there are a lot of multiple branches, not only one branch, there are multiple branches. The right side is considered more challenging than the left side because of the short renal vein. Maybe this is because the adrenal is sitting just on the vena cava. Then when you are going to approach from posterior, you have to prepare it from vena cava, and the vein is short, so this has to be a very careful dissection on the right side. These are some landmarks, as you can see. This is the first left, is then how we are opening the geratus fascia. The other one is the right side, is the artery, when you are reaching from posterior. Then the same kidney when you are going up, and if you see then the upper pole, the adrenal will be there. It's actually not long way to reach the adrenal. Can take from the beginning of the operation maybe 15 minutes. But the other job, careful job, starting thereafter. In this case, this is 10 millimeter bipolar device. Again, this is the right side, upper pole. Then blunt instruments. And once you reach the upper pole, then the things are getting easier. In this case, you have to prepare and let the kidney, at the beginning I'm leaving always the kidney hanging, then after I'm reaching the area, then I'm preparing also the ventral parts, so it will be possible to pull the kidney back, as you see here. Now the kidney is pulled back. And we are reaching the adrenal there. At the beginning is everything yellow, but you will see then, or you will be adapted with the time to the adrenal color, which is a little bit orange. Then you will be able to recognize it thereafter. Vena cava, adrenal. As you see, we are never grasping and stretching adrenal. It's always we are working around. This has to be, for me, what I have learned, don't play a lot with the adrenal. Go first, control the vessels, and thereafter remove it step by step. When you are going around, always step by step, always carefully. You see then it's the vena cava just behind. You have to be just careful. Once you are there, don't forget the vessels are coming from everywhere. The color is there, not very good, not really original color, but you can, I think, recognize the adrenal on the right side. And once this is done, always bluntly around and carefully and step by step. I think this is an old video because we are no more using this 10 millimeter device, then clipping the vessels. Not only the main, all the vessels. We are clipping all the vessels. Sure, the energy devices, they can seal the vessels 3 to 5 millimeter. It has been already described in the literature, clipless adrenalectomy, which is also okay. But for me, I will put a clip to sleep better when I'm performing adrenalectomy. And this is at the end, is the adrenal gland and adenoma, as you can see. And you see, all the steps are always clipping and cutting. Even small vessels, you can maybe control them with just bipolar. It will be clipped because we have seen this is then the adrenal vein. We have seen that this can be a big problem when you are not clipping. Step by step, all the vessels will be clipped and cut, and the adrenal is then free, will be then removed in endobag. It's very nice surgery for the patient, but not easy surgery for the surgeon, I can say. Maybe this will be okay. So on the left side, when you are going to the left side, is the same. You can use then spatial computer programs for recognizing vessels better. The SPICE program from Storz is this. But as you can see, then also adrenal can have a lot of vessels when you are going to operate. And you have to just control these vessels step by step and take all of them serious, not just cut. Because in this small space, if you will have this even small bleeding, it will be difficult to understand for you the anatomy. So it's not even the smallest bleeding is not to tolerate. It has to be as much as possible without any bleeding. So we have to go really the safest way when you are going into operating in this area. This was, I think, is a tumor case. This is the kidney upper pole on the left side, you see. Then if you just take it, kidney upper pole, these are the vessels coming from phrenic side. Once you recognize the adrenal, you have to just work around. And this step by step with clipping everything, even the smallest vessels. Because even this will drop here, one drop, this will make everything difficult with understanding the anatomy. The last vessels, and then the adrenal will be free, and then you can sleep in peace. That's why you will need always the clips, and clipless sounds nice, but for me it's putting a clip is always the safer way. Thereafter you see then this adrenal pedicle, then this big gland will be then endobag. Another problem with the retroperitoneal, you cannot go and operate very big glands retroperitoneally. It says a limit, I think then 4 or 5 centimeter maximum can be the limit. If the mass is bigger than this, sure, technically it's demanding. It's also not indicated to do it, to perform it retroperitoneally. How I can learn this operation? How I can learn this anatomy? Start always with mental training. Even when I'm going to operate tomorrow a routine case, let's say radical prostatectomy, I'm just looking a video before I'm going to sleep from radical prostatectomy to train mentally in my mind what I will do tomorrow. Always check the video and train first mentally what you will do. X-rays, adrenal location, videos, then you are ready. And this kind of videos you can find, as you can see here, in EAU website, in Surgery in Motion. They are then standard operating videos for every case. When I'm going to operate, even adrenal, when I'm going to operate, I'm looking at adrenal video. Maybe something new, I will see something. I'm training myself mentally what I will do tomorrow. Please, the equipment has to be full. Your team has to be trained. Your insufflator has to work, everything has to work, and you have to check it by yourself. Sure, everybody is responsible, but at the end you are the captain. You have to go there and then ask at least if everything is then working before you are starting with an important operation. Work along the landmarks. Don't try to find a new way. Be careful. When you see the adrenal gland, expose it adequately. Don't grasp and don't injure the gland, especially in tumor cases. Don't use the excessive force when you're retracting. You have to be always very kind with the adrenal, like you are dealing with a woman or with a baby, let's say. And then identify first the main vessels, control them, and then take care step by step for the others. Now is maybe this is what this operation I like a lot. Then Hans is also performing this kind of operation. I think the video I have taken from him. How you can approach the adrenal posteriorly. Firstly, the picture is totally different. You are looking almost from this side. Suddenly you have to turn it. You have to look from this side. The picture is then looking like this. I hope the video is working. Oh, no. The video is not working. Oh, yes, now it's working. You can do it. Very good. When you are going to the retroperitoneal space, as you see, this will be not very big when you are approaching the adrenal laterally extraperitoneal. And you need more pressure. You need pressure like 20. And the picture is like this, totally different. And your orientation will be also not easy. Maybe it's the best thing, as you see here, to find the upper pole of the kidney. Now you know where you are. And thereafter, go and recognize adrenal. Then don't forget, the cava is now on the other side, not on the right side, it's on the left side now, cava. That's why when you are going to operate such kind of case, to this access, I would go and see one video one day before or just the night before I'm approaching this. And as you see, this very, very, very direct access. The operation is taking shorter time. But the vessels are on the different side. You see, this is the cava, and this is the vein. So anatomically, you have to adapt yourself for such kind of approach. But at the end, once you can succeed, this is the excellent part. Your patient can jump and go without anything, go eat and drink. Then the adrenal area, as you see, is empty, and the upper pole of the kidney is there. You are done. Really very, very good approach if indicated. Sure, also for this approach, you cannot approach very big adrenal posteriorly. It has to be a limited. I would never go for me to approach such kind of case if it's more than 4 centimeter tumors. Then will be space, will be short, will be very, very thin. And now the mini laparoscopy. Mini laparoscopy sounds very well. It's actually existing during the long years, it's maybe 20 years, but at the beginning, the instrumentation was a problem. The quality was not very high, the instruments, they were not very stable and high quality. But it was needloscopic and the mini laparoscopic. But in the last years, we have re-evaluated this part of operations, and really successfully it's easy to perform also for the adrenalectomy. We are working with the 3 millimeter instruments and with 5 millimeter optic, or depending, you can use also 10 millimeter if you will anyway, you have to remove the adrenal through an incision. But it's really, really, really minimal invasive approach. If you have a young woman to remove a small adrenals, very nice approach. Posterior or mini laparoscopic, very cosmetic approach. Nowadays, the patients, they are asking for cosmesis. Everybody knows it. Everybody going to Botox, they will ask you, doctor, I want to be operated, but I have a tattoo here. Can you please take care for my tattoo? This is the situation nowadays. We have to take care. And these are the instruments. They are really very, very, very small. 3 millimeter instruments. This was 1998. Gil has just reported first time 25 years maybe before. Then in his scenario even, one of the main indications was adrenalectomy. Now, if you check the literature, in Europe, we are working almost when we are going to performing mini laparoscopy, almost 21% of the indications are adrenalectomies. Adrenalectomy is good indication also for the mini laparoscopy. Also, the operative time is getting better and better when our experience is also growing. Also, our instrumentation and optics are now better. I can remember our first 5 millimeter optic. This was terrible. Nowadays, we have HD 5 millimeter optic. It's similar like 10 millimeter. And you see, in Europe, it's the most commonly minimally invasive approach in alternative to conventional laparoscopy is the mini laparoscopy. And I hope this will work. Yes. How you can put the mini laparoscopic trocars. This is a video from Professor Porpiglia. This is the iliac crest, lateral flank position, 12 rib. He's putting always diamond-shaped trocars. And you will see he's using for the optic, if you have to remove the adrenal gland, anyway you need an incision. So you can use 10 millimeter optic without any problem. He's using 0-degree optic. And these are the mini laparoscopy trocars. These are the anatomic lines, posterior and anterior axillary line. incision, direct access to the retroperitoneum, not looking for the fascia and putting any stitches. No need. Don't invest your time for such kind of thing. Just go and pop the fascia and you are in the extraperitoneal space. The small incision, better you need a lubricant. You are just now here then in the extraperitoneal space. But this is all. This is all. He is using the finger like it, but the balloon will do the job at the end. This is the balloon. Once you are going with the balloon, then developing the extraperitoneal space. And sure, for me, I'm never using the optic trocar because I know where I am, but at the beginning to make sure then that you are in the extraperitoneal space can be very useful to use the optic trocar. Once you have developed everything, just taking it out, then you can put your trocars, 3 millimeter trocars. Nobody can find these scars thereafter. And this is during the operation with 3 millimeter instruments. There's also 3 millimeter bipolar, but you can use also this 5 millimeter, one trocar 5 millimeter. Maybe in children we are using likely 3 millimeter instruments, which is very nice. But if you need something more, you can use one of the trocars, can be also 5 millimeter. Same anatomy, only the instruments are 3 millimeter. The other job is the same, only with 3 millimeter instruments. If the instruments are stable, strong, it's no problem. This will work always. The most important thing is that the instruments, they have to be stable and strong. The beginning, the companies, they were not very willing to prepare or to produce such kind of trocars or instruments because it was expensive. It has taken with Schwarz maybe 10 years till they could develop this really good quality instruments, 3 millimeter. But now we have it. And you can use it for children, from the adults, for every indication, every minimal invasive indication. And this is with 3 millimeter, then this is the extraperitoneal, and this is the same approach at the end. Same approach we are doing with 5 millimeter, 10 millimeter trocars. You can do it also like this with the 3 millimeter trocars. Kidney from this side. Then when you are going to the kidney upper pole, then go to the adrenal space, because the fascias we have seen, and you can thereafter reach the area and take the adrenal. At the end is the same technique with the 3 millimeter trocars. We have done it one step more. We have described the small incision access retroperitoneal technique. You can use it. You can use it for every indication. We are using this for adrenalectomy, for pyeloplasty. The difference is you will need a 5 millimeter trocar for developing the space, balloon trocar. It's not commercially available. That's why you have to do it then by yourself. Otherwise, it's also possible, sure, with the 10 millimeter optic. At the end, when you go to the published literature, this down is the normal laparoscopy, then up is the mean laparoscopy, this transperitoneal access. You cannot find any scar even. It's really cosmetic operation, if indicated. As a conclusion, this some technical tips. Early control of the adrenal vein is important. If the mass is too big and there are then other problems like local organ invasion, venous thrombus, they are not suitable for the laparoscopic resection. It means not that we are accessing everything laparoscopically. Sure, open surgery has a place, but if indicated, laparoscopy is a very good option. The posterior retroperitoneal approach, you can go in one position, you can access left and right. And mini laparoscopy is really effective and cosmetic approach for selected patients. As you see here, this gland size, obesity, learning curve, that the most important factors influencing the operative outcome. In the right side is the section of vena cava is essential. On the left side, you have to go to the renal vein to find the adrenal vessels. At the end, the most important thing is the patient safety. We have to be always on the safe side, and you have not to operate for artistic reasons. It has to be indicated, open laparoscopic, transperitoneal, retroperitoneal. It has to be an indication that you have to be always for the safe side, and no place for artistic movements during the adrenalectomy. This can be very risky. And thank you very much one more time for your attention. We like adrenal surgery.
Thank you, Dr. Gozen. We know that you are a big supporter of the retroperitoneal approach, and you showed us again today this. So before moving to Dr. Langenhausen and his opinion about all that, are there any questions in the audience, please?
Actually, I'm expecting, the most important thing is that, are you performing adrenal surgery? Because this is mostly, in Africa, there are not a lot of urologists. Most of them are surgeons. There are surgeons they are taking for the job for the urologists, and it can be possible, not in the northern Africa, but then sub-Saharan area can be possible that the surgeons are operating adrenals. So maybe I hope and I wish that the urologists will take care more of the adrenal surgery and take it in their hands in the name of their patients. This is the message from my side. Yes.
Hello. Transperitoneal laparoscopic nephrectomy. How many cases we need the learning curve for the retroperitoneal approach? I'm personally performing transperitoneal approach for the for kidney surgery. So my question is, how many cases we need for the retroperitoneal approach? Thank you.
This, when you are working, not how many cases is just one of the criteria. It means then with which mentor, I'm operating alone or operating with mentor. If you have a mentor, somebody who can perform these cases, then will take care if something will happen during your case. You can start with a mentor, and if you will operate 10 cases with him, you can go by yourself. If you think that I have to learn it almost for every laparoscopic surgery, you will need in a year 30 cases. If you are operating, for example, adrenal, less than 20 cases in a year, how was it then for the insurance system? It will be not paid for you. You need a certain number of the cases, not only the learning. After you have learned it, you have to keep your experience with minimum number of 10, 15 cases in a year. Learning, I think you will you can learn it in 1 week. If somebody will stay with you, you operate with him 10 cases. You will be then extraperitoneal surgeon. It's fine. But to keep this level, you will need every year also some more cases. It's more important message, I think.
Thank you. Dear Dr. Gozen, I'm Nazim from Algeria. I have had a chance to come to Heilbronn.
No, Nazim.
3 years
No, again. No, not you. I was afraid, man.
3 years ago. My question is about the type of the optics.
Sorry?
I know,
Optic.
yeah, I know you use the 30-degree optics, and can we do a retroperitoneal approach with the 0-degree trocars? Because I had this difficulty.
Nazem, I cannot imagine that you have a difficulties. Okay, this is one part. The other part is, if you have 0-degree, you have to put the trocar, as Professor Porpiglia is doing, in the middle and then very on the iliac crest. You can see all the retroperitoneum. This will be possible. If you are working like we are doing, putting the trocar on the side, you will need a 30-degree. I think it's both of them that are possible. Even if you have the 0, you have to put the trocar on the correct place. But you cannot put 0 from the behind. This will be impossible to turn. But if you put 0 on the middle of the iliac crest, you will get an access to hold the space. Good tip.
Thank you very much.
You have to call it. You have to ask me per telephone call, man, not here.
Okay, thank you.
Unfortunately, we don't have enough time for other questions. For those who have any questions, they can ask directly Dr. Gozen after the plenary. And we can move to the talk of Dr. Langenhausen about the laparoscopic transperitoneal approach.
Thank you, Mr. Chairman. I'll try to compromise a little bit because I think we're running late and there's quite some overlap with Ali's presentation, so I think I can stick to the time. So yeah, I would like to talk on the transperitoneal or transabdominal approach. There's certain disease-specific considerations I would like to share with you. And can I go back? And a preparation for the transperitoneal approach and a few innovations we have. So yes, every adrenal disease, every indication, I believe, is different in surgery. So there's really disease-specific quality of the adrenals. For instance, in pheochromocytoma, the tissue is totally different from Cushing's disease. In Cushing's disease, we have very bad fat quality, very fragile tissue. The adrenal in pheochromocytoma is very highly vascularized, easily bleeding. So it needs a different approach from you to look at different surgical indications. I would like to mention the adrenal cancers, which is an extremely aggressive disease. And you have to be aware of the tissue, not to rupture it, because if you have tumor spill, that will probably mean a death sentence of your patient. So you have to think wise, can I do this laparoscopically or should I even move to open surgery? That's my main message. So I'm a believer of the retroperitoneal approach, specifically the posterior approach. I've been taught by Professor Waltz, who's a surgeon in Germany, and he's the pioneer in this field. And mainly I follow his advice to go up to 7 centimeters in a retroperitoneal approach, and only for benign tumors, because it's my strong belief that in adrenal cancers and adrenal metastasis, the chance for spillage in a retroperitoneal approach is much higher, and I would recommend a transperitoneal approach. And also, as Professor Gerson mentioned, the BMI. Obviously, with higher BMIs, all surgery gets complicated. And then specifically in the posterior retroperitoneal approach, I go up to BMI 35. Over 35, you see a lot of respiratory problems with these patients, and I tend to do a transabdominal approach. So, all other indications for me, transabdominal, and then I look at these disease-specific characteristics that are, in my belief, important to consider. So as you may know, already 30 years ago now, the first transperitoneal adrenalectomy was performed in a group of Quebec in Canada. And since then, it has become the mainstay of adrenal surgery, minimal invasive approach. And there's been several studies from, for instance, the urological literature from the Individual group. At that time shown there was no advantage for retroperitoneal approach over transabdominal, but in the later literature, as you can see here, this Barzinski group, also someone who's been trained by Waltz in Essen, He showed there's a clear advantage of a retroperitoneal approach in the smaller benign tumors in comparison to transperitoneal approach in recovery time, in blood loss, and in pain complaints. And I totally agree with these findings in the literature, and I'm, again, a strong believer of a posterior retroperitoneal approach for most of the patients. And then only for the larger tumors or high suspicion of malignant tumor, then the transperitoneal approach, to my belief, would be the preferred way to go. So how about the chance for a malignant tumor? We talked about the Hounsfield units on preoperative CT scan and washout if you give IV contrast, but also size can indicate there is a adrenal cancer. Below 4 centimeters, as you can see here, the chance of ACC, so adrenal cancer, is extremely low. Over 6 centimeters is really significant. And there's this gray area, 4 to 6 centimeters, where there is a chance of an ACC, but it's not really that high. So we had this consensus meeting a few years ago with European experts in the field in Paris, and we discussed all this. And because it is extremely rare disease, there's not much evidence to show you whether you can do a laparoscopic approach for adrenal cancer. But in the consensus meeting, we decided that up to 6 centimeters, when you're an expert laparoscopic surgeon and a clear suspicion of ACC, you could well do a laparoscopic transperitoneal approach. But the advice is over 6 centimeters to go for open approach in this consensus meeting. And especially when you see infiltration of the caval vein or the kidney, again, we advise to do open surgery for adrenal cancer. So, of course, there's contraindications, and just to mention a few relative contraindications, the bigger the tumor is, obviously it gets more difficult. So 7 centimeters and above is transperitoneal approach, in my opinion. That's higher than 8 centimeters, 9 centimeters. Specifically on the right side, it gets difficult, and it's probably wise to do open approach. And then specifically adrenal cancer over 6 centimeters, in general, the advice is to do open surgery. Well, anatomy is already mentioned by Professor Geusen, so retroperitoneal organ and the blood supply, I agree, it's totally predictable. There's about 50 to 60 small arterial branches running to each adrenal on the right side, on the left side, and running from the phrenic artery directly from the aorta and from the renal artery. So 50 to 60 small branches. And basically there's one dominant vein, a very short one on the right side and a longer one on the left side draining into the renal vein. There's always this phrenic inferior vein running as well on the left side and draining into the adrenal vein. And we see about 5–10% of variation, so that adrenals have another dominant adrenal vein, which is important, for instance, in pheochromocytoma surgery. You have to warn your anesthesiologist when you clip the vein, because then the adrenaline stops and the patient gets hypotensive. So if there's another vein there, it's important information during surgery. So preparation for a transabdominal approach, we do a lateral flank approach. It's also possible in a supine position, but I think it's more or less abandoned. So lateral approach, like in kidney surgery. And again, preparation of this position of the patient is really important for a good operation. Instruments, basically, I use a 30-degree optic. I think is very helpful in transperitoneal surgery. And I always use an energy device, either a harmonic, with the new feature now that you can do even 7 millimeters of vessels. The harmonic is really helpful, and ligature could also be a very good energy device to use for all these small arterial branches we just mentioned. So the patient here is with his head on the left-hand side. So this is the left adrenal. Basically, the trocar position is similar to adrenal. You use the Hasson trocar just cranially from the umbilicus, and then 2 instrument trocars, left hand, right hand, one of which should be at least a 10 to 12 millimeter trocar. And quite often it's useful to use a 5 millimeter assistant trocar as well near the iliac crest. basically, to get into the retroperitoneum, we have to mobilize the colon and enter the white line, as you can see here, and then free the renal hilum, try to identify the vein when possible, clip the vein, preferably as soon as you can, specifically, for instance, in pheochromocytoma surgery, and then move around the adrenal and free all the adrenal arterial branches with your energy device. I prefer not to use clips for these smaller branches, but I trust on this energy device. Free it from the kidney with ligaments, and then you can remove it in your endobag. So I have a video here. Might not be necessary to show the whole video, but we can have a look at some steps. And because we're a training institute, an academic center, we develop these instruction videos for our residents, and we sort of try to teach them in a modular way how to approach adrenals, and in this case it's a left adrenal operation. I hope it's running. So again, yeah, we like to pay attention also for residents at patient positioning. I think it's really important for successful operation. And then, as said, in this operation, you start mobilizing the colon, enter the retroperitoneum, trying to find the renal hilum, and then identify your adrenal before you start opening Gerota's fascia. The adrenal is within Gerota's fascia, and for that, you need to identify the renal vein, preferably first, and also the contours of the adrenal. Again, patient positioning, the lateral flank position. Make sure you pad knees and elbows, etc., to prevent compression points. And then we start to mobilize the colon, which I teach my residents using laparoscopic scissors. Why? Because it forces them to operate in the right anatomical planes without bleeding. And it's basically a training idea to use scissors in the beginning of this operation. You fully mobilize the descending colon, and then start to use your harmonic or your ligature and free the kidney and Gerota, and do a full spleen and pancreas mobilization on the left side. So splenopancreatic role is really important to get the right exposure to the left adrenal. Especially the assistant trocar can be helpful in quite fatty patients when the renal hilum is quite often medially located, and you need to lift the kidney with your assistant trocar to help you out finding the renal hilum and the adrenal. So based on contour, you can see and find the adrenal, and then you start opening Gerota's fascia. I try to open on the lateral side of the adrenal, so basically in between the kidney on the right-hand side here and the adrenal on the left-hand side, and then identify the renal capsule first. And just be aware of any upper pole arterial branches. So don't go in too deep straight away, but just work in layers all your way across the renal capsule. And in this way, you already freed the complete lateral side of the left adrenal, and then work your way downwards towards the renal vein that you can see here, and then try to identify the adrenal vein, which anatomically is easier than the right-hand side because it's longer, and you quite often see this inferior phrenic vein draining into the adrenal vein on the left-hand side. So I use clips for the adrenal vein in every patient. It makes me sleep better as well, I agree. And then once you've clipped you have to warn your anesthesiologist in case of pheochromocytoma that blood pressure will drop, and anesthesiologist needs to start the noradrenalines to put up the blood pressure. And once you've clipped the vein and cut it, then you can actually lift the adrenal and then work your way below the adrenal over the psoas muscle. And then the psoas muscle is a very nice anatomical landmark to mobilize the dorsal part of the adrenal. Basically, that's the part where you enter in a retroperitoneal approach. And since it's already mobilized on the lateral side, you've now mobilized it laterally, dorsally, and then finally you keep the medial side left for mobilization. And this is obviously the tricky part where the pancreatic tail runs and where the splenic artery and splenic vein run as well. So this is still the dorsal part. Now we lift it and then we work towards the medial part of the adrenal. And be careful here because this is where the main structures run that could be damaged in a left adrenalectomy. And then these are the last adhesions and the adrenal is being removed. So the right adrenal, basically similar trocar position. The only difference is that there's going to be an extra trocar below the xiphoid. It's here, it's close to the xiphoid, but in my experience it's easier to bring it back a little bit downwards towards the umbilicus for a right angulation to lift the liver. What I do is I mobilize the triangular ligament of the liver and then pull it up with this retractor clamp, put it in the extra trocar, and then by doing this, I'm mobilized in the duodenum. You already see the adrenal on the right side, and steps are quite easy from that, except for the adrenal vein that is obviously very short on the right side. So what are the innovations going on? A lot of questions I get is, should it be done by robotics? There's been some studies on this topic. There's been a small randomized trial from the surgical literature in which there was no clear indication for robotics in adrenal surgery. It was more expensive, even more complications in that series. But there's a very interesting series, the second one from the European urology publication in partial adrenalectomy, and I'm a fan of using robotics in partial adrenalectomy, especially in pheochromocytoma patients, where I mentioned the hereditary pheochromocytomas. They tend to recur in the other adrenal, and then it's sometimes a better choice to do a partial. There, the robot can be really helpful, in my opinion, to use for partial adrenalectomy. And there's even been a randomized trial to compare robotics, transabdominally versus the retroperitoneal approach. And again, here, a retroperitoneal approach was preferable in every aspect over the transabdominal approach. So for me, using the robot, definitely not something standard if you have a robot in the first place anyway, because obviously it's expensive and not very widely available worldwide at this moment. But for some patient indications, specifically partial adrenalectomy, it could be helpful. Or for a case like this, in which we have a right-sided pheochromocytoma, and in this same patient, the right image, this patient had a paraganglioma, so a lesion on the aorta, on the bifurcation. And for this specific indication, I use the robot. It's easier to work in different quadrants with the robot. So there could be an indication there. But could also be an indication for larger tumors to make life easier. Although, on the other hand, I have to warn, if it's a large tumor and really suspicious of ACC, then I recommend even to do open surgery at this moment. Training education, it's easier to train the residents on the robotic system than laparoscopically. That could be a reason for you to use the robot. But definitely for me, it's not something standard for adrenal surgery. So again, the multidisciplinary team, I would like to stress it again. I think it's really important. I like to choose the operating team per individual. So I have a preference for a retroperitoneal approach, but transabdominal for the larger tumors, maybe the more difficult tumors, and for the malignant tumors. And again, be aware of adrenal cancer because you have one chance for a cure, that's a good operation. And if you can't do it laparoscopically, please don't, and just do a proper open operation. Thank you very much.
Very much, Professor Langerhausen, for this excellent presentation. We are out of time, so we have only time for one question from the audience, if there is one. Okay, it was clear, no questions.
Thank you.
So we will skip the break because too late. So we move to the next presentation by Professor Golden.
Now we are going to the nightmare parts, the complications. Complications are happening with everybody. If you think that this will not happen with you, it's a big mistake. When you are going to operate, you will have also complications. So the solution is first to be prepared. Sure, to prevent is the best way. But if this is happening, you have to know also which way you have to go. This is maybe the more important than preventing sometimes. We have told then the anatomy is challenging, and then the surgery is also challenging. These are the gold standards. Actually, the messages here. When laparoscopy has been one of the standard tools for us, also for the adrenal surgery. But it's also, they have brought also some complications with it. Okay, something is progress. It's very good. If you are a surgeon and you have no complications, it means you are operating not. If you are operating, you will have complications. That's why I like it from Dr. Desai. A surgeon without complications is either a stranger to the truth or has not done enough surgeries. If you are working, you will have complications. You will have these complications, 20% of these complications during your first 20 cases. It means when you are going to start with an operation, serious, let's say adrenalectomy, you have to be prepared. During the first 20 cases, statistically, you will have 20% complications. And after this 20 cases, this complication rate will drop to the 4%. It has not to be the lethal complications, but you will have problems anyway. A good surgeon is better, has to know how to deal with these complications. But sure, it's better how to avoid them. The complications we can classify actually easily related to the anatomical topography of the gland and related to the minimal invasive access. It's mostly posation, access injuries, vessel injuries, bowel injuries, pleural injuries, and maybe the less known problem is with the adrenal surgery, especially with the left side, the pancreatic injuries. This can be very, very serious. That's why what I'm telling from the beginning, when we are dealing with the adrenal, especially on the left side, we have to be very, very careful. Next slide. Okay. First, we can start with the position. If you are not padding your patients
Recording in progress.
from the beginning, putting on the table not in a correct position, that's not taking care for the padding, you will experience some neurological related to position problems. You have to avoid metal contact. You have to take care for bedding enough. You have to be prepared for a long surgery and be aware of the crash and compartment syndrome. All of this, actually, they are standard problems. In the meantime, adrenal surgery is not taking long time. And then these are, actually, this is a standard. You have to take care how you put your patient on the table. Then we take care for metal contact, and if you take care for the padding, is done. Most of the complications with the adrenalectomy are, as you see, vascular bowel injuries, injuries to the liver and spleen, pleural injuries, and pancreatic injuries. The bowel injuries and liver and spleen injuries, they're mostly happening, or maybe all the time happening with the transperitoneal surgery. The others, pleural injuries, pancreatic injuries. Can you remove this? Thank you. This can happen also during the other surgeries. You see here then how many complications they can happen then during the adrenalectomy. You see, it's really not very, very big complications where they are quite rare complications, but when they are happening, this can be done very, very serious. This is in a German way. I want to underline here the pancreas fistle. This fistling from the pancreas can be a big problem and can take long time. When you are performing posterior retroscopic procedures, adrenalectomy, it's a long series. This is with the posterior access. As you can see here, really these are the general problems, but conversion to open procedure is only in 9 cases under 560, which is actually nothing. It happened. It's happening with everybody. You have a complication. The most important thing is you have to know if this will happen with you. It's like in case of fire, you have to know in which direction you have to go to leave the building. First, how I can prevent is sure, but more important is early recognition. If you have injured the bowel, for example, you have to recognize it early, because if you will leave it or you will not be able to see this, patient will go to the sepsis, maybe will die, which is the very, very dramatic end. It's better to know the early recognition, and then if you recognize it, you have to know how to manage this during the operation. If possible, laparoscopically. If not possible, sure, you have to convert on without thinking long time. Start with the first problem. When you access and trocar placement, I'm using always the open approach Hessen. In this way, when I'm going also in transperitoneally, the injury, especially in the previous operated abdomen, is always, the possibility is less. If you go with Hessen technique, you will actually skip the injuries when you are going blindly with the first trocar. Put the trocar safely always under vision when you are going transperitoneally, and when you are going to retroperitoneally, always under digital or optical control. Know the abdominal wall anatomy. You will see, you will know where are the vessels, where are the epigastrics. You will be able to take care for this. If the patients, they have been operated already several times abdominally, you have to choose the retroperitoneal way. I think this video was not working. We tried to manage it maybe today. This is retroperitoneal access injury. It's always not easy, like we are showing the access to retroperitoneum. If you are not in the retroperitoneum and you think that you are in the retroperitoneum, you can also inflate your balloon between the muscle layers. Then you can go with the optic and you are nowhere. That's why you have to first feel with your finger when you're going in the psoas muscle to avoid such kind of injuries. I like it. Injuries to the vessel and bowel. Mostly these are done for vessel injury. Mostly this is done epigastric vessel injuries. When you are taking care for this, when putting your trocars under vision, this will not happen. But if you are rushing and you want to put the trocars very fast, and you are an artist and want to show everybody how much you can do it and you can do it better, guys, can you remove it? Please. This can make the things difficult. It's better make it done safely and step by step. Bowel injury, if you are mostly happening when you are putting your trocars and when you are using the energy, these two options. When you are putting the trocars transperitoneally without taking care, when you are using excessive force when you are putting the trocars, when you are using excessive force, if you haven't cut adequately, if you haven't cut the fascia, you have to push more. Then you can lose the control in these cases. When you are using energy devices, don't fire them very close to the bowel, because you can also cause then injuries, terminal injuries. This will end after some time with the necrosis. There are not a lot for the adrenalectomy cases, but on the other hand, when you're looking all the injuries, is the most frequent complication during the adrenal surgery. And when it's happening, any vessel injury during adrenal surgery, these transfusion rates are really very high in such kind of cases. It means it's really bleeding because the adrenal vessels are coming mostly from main vessels. How we can avoid and manage vessel injuries? You have to study the anatomy. If it's the small vessel injury, it's a venous injury, then just increase the pressure. You can increase the pressure till 20. But if it's a small vessel injury, you can put a pad or small gauze onto the bleeding site to gain some vision and localize the bleeding. You can apply hemostatic agents. Tacocil is the most effective one, but don't forget, one piece of Tacocil costs 200 euros, which is very, very expensive. If it's something happening, you need an exposure. You need first to know where is the bleeding, which vessel is bleeding. If you gain access and vision, then you can go and apply electrocautery clips or stapling devices. Laparoscopic suturing, if you are very, very experienced, you can attempt laparoscopic suturing, but if you are not operating a lot and you are not an expert, don't go for laparoscopic suturing. Better convert quickly to an open procedure. Converting to open is not a shame. At the end, you have to take care for the life of your patient if it's necessary. If this is your limits, you have to convert, and without thinking a lot. During your first cases, when you're going to perform adrenal surgery, minimally invasive, it's better to keep an open set ready for such kind of possibility. You will not lose anything. Can you run the video? Can you run the video? Was working today? This is also nice. It's under this was the prone adrenalectomy. One of the big advantages of the prone adrenalectomy to work with very high pressure. When you are working with very high pressure, in these cases, even if you will injure a vessel, small vessel like vein, even this is then the adrenal vein, main adrenal vein, at the first time, in the first seconds, this will not bleed because of the very, very high pressure. This can be one advantage. Can be working the video before? Is not working. Can you check the video once? Maybe. So I'm sorry, videos we have checked today, but the videos is every time happening. Which one? Just one before. It's on the right side. Complication valves. Right side. Right up. Total failure. Excellent. This was the wrong button, man. Wrong button. It's okay. It's if the pressure is high, this can prevent some complications. It's maybe one of the advantages when you are going extraperitoneally and in prone position. Even if the small vessel injury will happen, this will not bleed. This will give you time to recognize the vessel and control the complication maybe. The other complications with the extraperitoneal approach is when you are approaching, especially on the right side, putting the trocars. Once you are in the extraperitoneal space and you can put your left side trocar below the ribs too high, you can injure also the pleura. Your trocar can go directly through the pleura when you are putting your trocar on the right side too high. This is one of the beginner complications when you are starting with the retroperitoneal surgery. It's okay, adrenal is the correct one. Adrenal complications. Second one. Yes, sir. Now, European ESU 2022. Left. One more. Yes, this one. Okay, this is very good. As if this will work. Actually, as you can see, I have a lot of videos embedded. I hope we will be able to show you here. Or you can show the videos one by one if this will not possible. Okay, can I go? Let's say. Oops, sorry. This is one more. Bowel injury is not working. Oh, it's okay. Now, this is then, you see here, this is the colon. This is the trocar injury in the colon. You see? If you are putting your trocar without controlling your power, you can go directly in this case, this was like this. This is happening very nicely. But when you are an expert, you can repair this endoscopically during the same operation. But if you are not an expert and you don't know what you have to do, ask somebody to help you. This can be a senior colleague, or it can be a surgeon. At the end, if you know, it's fine. You see, the problem can be solved like this. But if you don't know, then this is a problem. The more bigger problem is if you don't know, but you are confident, and we name this in the urology stupidness. Now you see this is also possible to repair once you will recognize the problem. The other one is this is the right side extraperitoneal approach. Then you are putting the trocar too high. You see on the left side, the trocar, the instrument is going through the pleura. This is the pleural injury. If you are putting this too high, below the rib, this can happen with the pleural injury. You can put a drain. It's not a very dramatic situation. Don't be afraid. Then it's fine. But you have to put a drain there, the thorax drain, to solve the situation. It's also what you have to know. This incidence is not very, very high, but mostly at the beginning when you are putting the trocars and then during your initial dissection, this can happen. And mostly small defects, and then you have to insert a thoracostomy. More important, life-threatening, this is the pancreatic injuries. Pancreatic injuries really, on the left adrenectomy, very high actually, higher than I have expected, but this paper was published maybe 10 years ago. Maybe now we have the better numbers, but really very high. If you don't know how you have to deal with the adrenal on the left side, and if you don't know where is the pancreas tail, this can happen. You have to be careful and you have to dissect non-aggressive on the medial side. It's no sign during the surgery. You think everything is okay, but thereafter you will experience, or patient will experience pancreatic fistula, abscess, drainage. This is very big problem, and it's taking very long time. It's better to keep away from pancreas, and then when you are going to the left side, be careful. Trocar site injury. If it's done, you put your trocar and then you have then the epigastrix inside. So these are some devices. As you see here, this is a multi-use device. There are also single-use devices to control these areas. This is the finger inside. There's a vessel injury. Then you can manage it through the same incision, and you can control the bleeding. If necessary, don't hesitate to go and coagulate. Even you have to put a clip to the epigastrix because they are bleeding very bad. This is one of the actually, as you can see, options how to close these trocar sites from inside, and how to control bleeding if you have an epigastric injury. How to avoid and manage, you have to access carefully. If you don't know, prefer open technique. If you are going to approach the previous operated abdomens more carefully, use energy sources also carefully. Keep away from the big vessels. When you are touching with the, for example, harmonic scalpel, vena cava, you can make a hole. When you are touching any other vein, it's easily you can make a hole. Stay away. When you are going to prepare bowel, better with scissors, not with energy devices, because when you are coming too close, this can make thermal injury. When is then the bowel injury is happening, you can use freehand suturing. But if necessary, don't hesitate to open or ask for help. The same video was working. This video was working. It's not. Yes. Okay. This is the same video as I have seen also during the This is the, you see this is very classical video. When you are using excessive force and trying to prepare the upper pole of the kidney, especially this device, the surgeons are mostly using this for preparing the tissue bluntly. In these cases, better don't use it. Be careful. On the vein, performing its preparation with this device and with really applying a lot of power is really ending like this. This is a right side adrenalectomy. When you are going there and preparing the kidney, and then you are going to the adrenal. This can be this adrenal. You see this adrenal vein. This was bleeding at the beginning, and then this could be prepared thereafter. The same video, sorry, this one more time. This was bleeding from the adrenal vessels, then could be controlled with clipping and putting a white clip. The adrenal vessels can bleed all the time. That's why I'm telling put always clips, especially the white clips or polymer clips to do it then safer. Is a golden gland, some golden rules for the golden gland, optimal preoperative preparation. You have to study the computer tomography or ultrasonography. You have to place your trocars carefully under direct view, if it's then going transperitoneally. And you have to avoid manipulating the instruments. If you cannot see the tip, don't play around with your instruments, always under view. Once you complete the procedures, don't be happy. Just check the field one more time before you are leaving the abdomen. Then some of the venous bleedings, especially in adrenal operations, they have to check they are coming thereafter once no more pressure is inside. And convert if necessary, sure. Is this video working? Can you work this video? Yes.